Good afternoon. I'm John Holman. I'm Vice President, Medical Affairs at Transplant Genomics. I want to thank all of you for joining us for our symposium on the path beyond COVID-19, management of kidney transplant patients using TruGraf for surveillance. We have an outstanding group of speakers this afternoon who will share their experiences using TruGraf, especially in these challenging times. So let's begin. Our first speaker is John Friedewald. Dr. Friedewald is a transplant nephrologist and an associate professor of medicine and surgery at Northwestern University Feinberg School of Medicine. He has an extensive clinical and research experience with the TruGraf assay, and John will share with us an overview of the TruGraf assay. John.
Here's my disclosure slide. So let's start with what TruGraf is. TruGraf was designed with a specific purpose. So some tests are born looking for a disease. We actually started with a specific disease and developed the TruGraf test. TruGraf is a blood gene expression profile developed specifically to detect the absence of subclinical rejection in stable kidney transplant recipients. So what is subclinical acute rejection? How do we define it? Actually, we define it very tightly. It's defined by three things: having normal renal function, defined as a serum creatinine less than 2.3, stable renal function, less than 20% change from the prior values, and you have to have rejection on a surveillance biopsy. That defines subclinical acute rejection. And we've learned a lot about subclinical rejection in the last couple of years. On top here is a paper that we did reporting the findings of the CTOD-8 trial, where we developed and validated a novel blood-based biomarker for subclinical acute rejection after kidney transplant. But also, and importantly, we further defined in a large multi-center trial the frequency and importance of subclinical rejection, critically that even borderline infiltrates or rejection are meaningful in terms of effect on clinical endpoints. These findings were echoed in several other important publications in the following year. A group from Pittsburgh, from University of Alabama, Birmingham, the GOCAR study led by Barbara Murphy, and the group from Australia all published papers showing very similar clinical findings related to the disease of subclinical acute rejection. So how often does this happen? Is this a rare disease? And the answer is no, it's actually fairly common. In the CTOD-8 trial, for instance, all patients had surveillance biopsies done at 3, 12, and 24 months after the transplant. And what we found was that there was about a 20% point prevalence at 3 months, 25% at 12 months, and it persisted. 25% of people had it at 24 months. Overall, 35%, 1 in 3 patients in the study had at least one biopsy with subclinical rejection in the first 2 years. So it's a common finding. And we also found that about 80% of the rejections detected on biopsy were read as BAMF borderline infiltrates, with 20% being 1A or greater or antibody-mediated rejection. And subclinical antibody-mediated rejection is defined the same way: stable renal function, normal renal function, but a biopsy showing rejection. So what are the consequences of subclinical rejection? This is the so what part. Well, so what has been shown that subclinical rejection is associated very tightly with higher risk of going on to later develop clinical acute rejection. That's where you have an increase in serum creatinine. People in all these studies were more likely to form de novo DSA if they had subclinical rejection. They were more likely to lose their graft at 5 years, more likely to develop graft fibrosis on a biopsy at 2 years, and they had a more rapid loss of GFR over the course of these studies. And these are just some of the figures from the studies. This is the GOCAR study showing that those that had subclinical rejection at 3 months versus that didn't had a lower graft survival out to 5 years, statistically significant. This is data from the Australia group showing progressive interstitial fibrosis in those that had subclinical rejection versus those that didn't. These same findings were found, by the way, in the GOCAR study and the CTOD-8 study. I'm just showing individual representative samples here. And then in the CTOD-8 study, this is de novo DSA, we found that patients that had no subclinical rejection had lower rates of both class 1 and class 2 de novo DSA compared to those that had at least one episode or multiple episodes of subclinical rejection, much higher rates of de novo class 1 and class 2 donor-specific antibodies. So all things that are bad in terms of graft outcomes associated with subclinical rejection. So how do we discover the test, and what is the test? TruGraf is a gene expression test, and the way we did this is we got a large group of patients from these trials, a bunch of patients that had normal biopsies, normal function, and stable function. That was called TX, or transplant excellence. Then we had a large group that had subclinical acute rejection, again defined, as I said earlier, with stable function, normal function, but a biopsy showing rejection. And we took these two groups and looked at their blood and ran a gene expression profile using an Affymetrix gene chip. And we come up with a bunch of genes that can be put through this bioinformatics pathway shown here. And we created what's called a random forest model. And what that does is it asks the question, what are the set of genes that best tell these two groups apart? for a very specific reason. And what we found, the TruGraf gene expression profile consists of 120 genes that are either up or down regulated and specifically chosen to distinguish stable normal biopsies from those with subclinical rejection. So again, this is a test designed for a specific disease, and it's very good at detecting and differentiating those two diseases. How does this test perform? It's been shown now in other cohorts. This is a paper published looking at patients from 7 transplant centers shown here using the TruGraf test. And what we find is very consistent, a very high negative predictive value around 89 or 90%, meaning that if you have a negative TruGraf test, which is a TX result, transplant excellent, there's a 90% chance that that biopsy would show a normal biopsy. The positive predictive value is lower, right around 50%, if you have a non-TX result, which is the opposite. And you can see the consistency of the accuracy of the TX result across the sites in this one study that was published. So now what I want to do is walk through a few actual patient examples to see how biomarkers can be used in managing stable patients. And I'm combining this here with the TruGraf test, another test called the TRAC test, which is a cell-free DNA assay. And so this patient, this is an example of subclinical rejection, subclinical AMR. So here's a patient that's transplanted, and they're followed for 24 months in the trial. And importantly, all these biomarker results were obtained retrospectively, so that they were not used at the time of this trial. This was an observational trial, so they did not inform the management. Only the biopsies informed the management. But all patients underwent protocol biopsies. So this patient had a protocol biopsy at 3 months per the protocol. The TruGraf assay was TX, transplant excellent, which means that it's likely there'll be a negative biopsy, and sure enough, the biopsy was negative. So this is an example where if you had a TX blood result, you could avoid doing this biopsy and be fairly certain that you're not missing subclinical rejection. The patient had, again, retrospective, a cell-free DNA TRAC assay done, and this is below the cutoff of 0.69, so it was a negative assay as well. You can see the patient had excellent and normal renal function that was stable throughout the 24 months. So again, if you didn't do biopsies or didn't do biomarkers and just followed serum creatinine, you would think this person was doing fine. But in fact, what happened to this patient, as they move on now at 4, 6, and 9 months, at 12 months, they again undergo a protocol biopsy. At this point, the TruGraf assay is non-TX, so it would tell us that probably there's at least a 50% chance that there's something going on other than a normal biopsy. In fact, the patient is found to have subclinical antibody-mediated rejection. And interestingly as well, we know that a cell-free DNA, the TRAC assay, is a very sensitive assay for endothelial injury, often caused by antibody-mediated rejection. And so in this patient, the cell-free DNA pops up as well and stays up here as the person's being treated. They're treated with rituximab and IVIG. Now, one of the things we found in the CTOT trial, and other people have shown as well, is that subclinical inflammation is very persistent. We think we treat it successfully, but if we don't do a follow-up biopsy or biomarker, we may be missing incomplete treatment of the disease. And in fact, that's what happened in this patient. So 3 months later, they undergo another biopsy, again with perfect stable renal function, but they have subclinical antibody-mediated rejection. Again, the TruGraf assay is non-TX, suggesting that that's what we would find. And still, the cell-free DNA assay is persistently elevated. They're again treated with another round of IVIG. Now the cell-free DNA assay drops. And one of the real probably benefits of cell-free DNA is monitoring response to therapy, particularly for antibody-mediated rejection. Cell-free DNA comes down, creatinine stays stable. The patient goes on the study, and at month 24 has another biopsy. Now the TruGraf assay is TX, and the biopsy is back to normal. So in a sense, we could have potentially avoided 2 biopsies for this patient, but in the meantime, done biomarker-guided biopsies here to detect subclinical injury and treat it successfully, and then monitor response to therapy with a cell-free DNA and a TruGraf assay. And the next example, another patient, again, same setup here. Patient's transplanted, has early blood samples done, again, retrospectively. Pretty good kidney function, creatinine 1.3 at month 2. They have a first TruGraf assay, which is non-TX. Turns out we don't have a biopsy at that time, but it's likely a false positive. By the second month, the TruGraf test is TX, suggesting that things are quiescent. At month 3, again, a TX TruGraf result. Biopsy's done, red is normal, mild fibrosis and tubular atrophy, grade 1. By month 12, now there's a gap here of 9 months. By month 12, creatinine's still pretty stable here. TruGraf assay is TX, and again, the biopsy is normal. At this point, cell-free DNA is also run, and it's 0.42 using the TRAC test, and that's below the cutoff for positive, so everything's doing fine at this point. Now, this patient, there's a gap here of about 8 months. The patient at month 20 has a rise in serum creatinine. You can see up to 2.0, almost 2.1. They have a for-cause biopsy done. Now, TruGraf is not indicated during the times of an instability. So this patient doesn't have stable renal function, so we don't do a TruGraf, but they have a biopsy, and it shows AMR and with some potentially chronic features. Patients treated with steroids, IVIG, and plasmapheresis. 2 months later, they have a repeat TruGraf assay. It's still non-TX, and we can see that cell-free DNA is run here. Now it's positive and still going up at month 22 and 24. Sure enough, in month 24, they're rebiopsied, still with a non-TX TruGraf, and again, they still have subclinical AMR. Now they progress to second-degree interstitial fibrosis and tubular atrophy. And the patient, again, is then retreated. And what this tells us is the patient probably wasn't adequately treated here, and either the increasing cell-free DNA and or the positive, the non-TX TruGraf, would have indicated that maybe we should have biopsied this person earlier. Again, being an observational trial, these test results were not available at the time. Another example, again, of subclinical rejection. This one's a combination of cellular and antibody-mediated rejection. And again, it highlights that if you look at the serum creatinine here in orange, if you just follow creatinine without biomarkers or biopsies, you would be missing a lot of things in a patient. So here's a patient transplanted, again, good kidney function. At month 3, they have a TX TruGraf, so you could have avoided a biopsy, but the biopsy's done, and it was normal. And again, they have a low level of TRAC cell-free DNA. Patient cooks along here, doing well at month 12. Now they have a non-TX TruGraf, biopsy's done, and sure enough, they have borderline subclinical rejection with now grade 1 IFTA, which wasn't apparent at month 3. Now, we don't, again, in the study, we didn't have these TruGraf assays along the way here, but the question is whether earlier on this would have led us to intervene back here and avoid some of the fibrosis we see. But the patient decided that the clinician treating the patient at the time decided not to treat the patient based on borderline infiltrates. Again, the patient has stable function. All they go here with these intense monitoring visits a few weeks later, a month later, and then 3 months later, they have a non-TX, persistent non-TX. Again, a biopsy is done, still showing borderline acute cellular rejection. Now the patient's developed de novo DSA and antibody-mediated rejection. At that time as well, TRAC is done, cell-free DNA is positive. Patients treated with steroids, IVIG, and rituximab, and they continue on here. Unfortunately, several months later, still with stable renal function, they have a non-TX TruGraf assay at 24 months. Biopsies done, still showing AMR. At that time, the cell-free DNA assays really shot up here to 9 and almost 10. Again, treated with another round of steroids, plasmapheresis is added now in IVIG. The DSA get better and the patient improves. So again, if you're just looking at serum creatinine, you're missing the picture here. The last case I think I want to present here is a patient that underwent HLA desensitization. And again, when we think about the tests we use and the biomarkers we use, you have to understand the patient population that you're treating and what their pretest probability is. So this patient is transplanted and under the protocol for desensitization at a 1-month biopsy. At the time, the TruGraf assay was TX. Biopsy was read as normal. Interestingly, good renal function here, creatinine 0.8. At that time, a cell-free DNA assay was above the cutoff of 0.69, so it was positive. So the TRAC assay is positive. 3 months, patient has their standard 3-month biopsy. Again, it's normal. TruGraf assay is TX, and the cell-free DNA now is slightly higher. Patient, again, is monitored with their renal function, 6 months, 9 months doing well. At 10 months, still stable function, but now they develop proteinuria, and a for-cause biopsy is done at that time, showing subclinical, because the kidney function is stable and normal, subclinical antibody and cellular rejection. Now, interestingly, as we go back and look, the cell-free DNA TRAC assay has shot way up here to almost 7.5, and then at the time of biopsy is still almost 5. Treatment with steroids and IVIG is given, as well as increasing baseline immunosuppression. The cell-free DNA assay continues to improve. Gap in time here from 13 months to 24 months, but by 24 months, still stable function with the same creatinine they started with. The TruGraf assay is back to TX, and the biopsy is back to normal. So in summary, I hope the data and some of these clinical examples have shown you that TruGraf is really the only available non-invasive biomarker to rule out subclinical rejection reliably in stable patients. And by doing that, you can avoid the need for protocol biopsies. Now, some centers don't perform protocol biopsies, but as I showed you, if you're just monitoring serum creatinine, you may be missing subclinical disease, which may be clinically very relevant for your patients. Again, subclinical rejection is common. 35% of patients in a large cohort study developed it in the first 2 years and was associated with inferior graft outcomes, which are important. Further episodes of acute rejection, donor-specific antibodies, lower GFR, fibrosis, and graft loss. Monitoring with TruGraf can provide confidence that your patient's not having subclinical rejection and prevent the need for invasive biopsies. Or conversely, you can do a biomarker-guided biopsy that may detect subclinical injury and allow treatment. And again, cell-free DNA is a reliable marker of endothelial injury, most often caused by antibody-mediated rejection. It can help in the management of patients with ongoing antibody-mediated rejection. With that, I'd like to thank you. I appreciate you attending today, and I look forward to the next time we can talk and meet in person.